Hello, good morning. My name is Mary COUGHLIN. I am the president and founder of Caring Essentials Collaborative. I'm a neonatal nurse practitioner by training, and I'm very honored to present to you today on the topic of love in the time of COVID-19, trauma-informed care in the newborn intensive care unit and beyond. I understand this is going to be a mixed audience of nurse practitioners, and I'm delighted to share this information with you. My core competency is in neonatology, but I do absolutely acknowledge the implications of this paradigm that I'm going to share with you across all patient populations. So if I don't specifically address your patient population, please, walk with me and see how this concept resonates with the individuals that you're blessed to serve. Okay, so, So love in the time of COVID-19, you might be thinking, what is she talking about with love? So I adapted the name of my talk from a very famous manuscript written by Gabriel Marquez, who wrote about unrequited love during the cholera epidemic a million years ago. And what I liked about the story was just that the resilience of love and how love is a healing experience that impacts everyone. It's contagious in the best sense of the word, and it lives beyond its expression. And I think it's an underutilized tool in our toolbox as healthcare professionals. So as we move through this presentation, I want you to think about, what does love look like in your clinical practice? How do you manifest love? How do you express your love of other in the work that you do? Is it through, quiet time spent with the patient? Is it introducing yourself before you lay hands on the patient? Is it your patience as you're coaching a patient through their rehabilitation? What does it look like? Because oftentimes it happens and we don't identify it. We don't recognize it as an expression of love. And that's really, I think, the essence of the work that we do. And I know I'm not alone in this when we look at the history of nursing and we look at the work of Florence Nightingale, which was certainly directed by her love of others and her love and concern for the health and wellness of vulnerable populations. We see it in the work of Jean Watson, relatively contemporary nurse theorist, or at least a contemporary of mine when I was going through nursing school, who founded the theory of caring science, and where she's continued to do an extensive amount of work looking at the effects, the physiologic, psycho-emotional, and spiritual effects of authentic healing presence, authentic caring, and caring moments in the course of the work that we do. It was Florence Nightingale who actually said, as nurses, we are called to manage the human experience of disease. Now, while we're doing that, we're also supporting and managing the disease in collaboration with our other colleagues, physicians and therapists and the like. But our first admonition is first do no harm and to manage that human experience. And we do that through our love. And of course, where our love is really challenged right now, the expressions of our love and the work that we do is thwarted by this global pandemic. Because what this pandemic is doing is it's triggering all of these emotions that are arising as a response to resource constraints, frustration over the limitations that we have in not only doing our work, but actually living our lives, interacting with our own family as we come on shift and we do the work that we do, and then we have to strip down and decontaminate and be concerned about the threat that we may be posing to our own family and loved ones and friends. So this is just a short list of some of the emotions that I think many of us are feeling in this field within healthcare and even just in the general public. Anger, fear, anxiety, isolation, and frustration. And think of this, through your lens as a clinician, but also think of this through the lens of the patient and for the family, and how they may be experiencing very similar emotions. And in that recognition, we see our shared humanity. And that's really where I think the foundation for trauma-informed care emerges. The idea of trauma-informed care is really shifting the paradigm from what's wrong with you to what happened to you. And what's interesting to me, at least, because this particular framework has been around in mental health for over 50 years, I was just introduced to it about, I don't know, about 10 years ago, and saw the relevance within neonatology. And of course, in this work that I've been doing, I also now see this isn't just for neonatology or behavioral health. This is for everyone. Because when we look at the results of the ACE study, the Adverse Childhood Experience study, we'll see that adversity is pervasive in the human existence, right? There's all different shades and colors of adversity, but we're all exposed to it. We all experience it. And I think we tend to downplay the implications of this adversity, of trauma experiences, on not just our biology, but our psychology and our spirituality. And so through this talk, I'm hoping to realign you with that connection and the totality of who we are as humans. We are truly greater than the sum of our parts, as are our patients and their families. And we need to be reminded of that so that we can really bring the best service to them. And when we bring the best service to them, that's when we enjoy, right, the best results of that active service. This is the original study was published in 1998. The work itself was done, prior to that period when they were collecting the data. And what they had noticed, that there seemed to be a link between childhood experiences and adult morbidity. Specifically, the study was kind of birthed out of a discovery around the work that was being done by Dr. Felitti, you can see here on my slide, and his team, who had put together an obesity clinic and had a really brilliant strategy or intervention to manage obesity. They were enjoying a significant amount of success with their intervention until one patient came along and started to backslide a little bit on her progress. And they dug and dug and dug to try and figure out what was going on with this woman. She had been making great progress, but all of a sudden things halted. They had an interdisciplinary approach. They interviewed her, couldn't figure it out, and they said, okay, come back in a month and we'll see where you're at then. And the woman came back in a month and she had gained 50 pounds, which the lead author here, Dr. Felitti himself, said, I thought that was physiologically impossible. What is going on? The gloves are off. We need to figure this out. And as they delved more and more into her history, into her background, what they discovered is that she had actually been molested as a young girl by an older family member. Now, fast forward to her current situation, as she has been losing the weight in the obesity program, apparently an older work colleague started hitting on her, and it triggered a trauma memory. And she started reverting back to her old patterns of how she was hiding herself physically. So the team thought, well, this is interesting. Is it too true but unrelated, or is there something to this? And so what they did was they created the Adverse Childhood Experience Questionnaire. This was a questionnaire. It had 10 items on it, and it asked the respondents questions about their childhood from as early as they could remember to age 18. Did they have any experiences with abuse, neglect, or household dysfunction, which you can see described on this slide? They disseminated the questionnaire to their network, which included 17,000 people. It was a Kaiser Permanente managed health network out in California. And the results were pretty mind-boggling. 2/3 of the respondents had an ACE score, an Adverse Childhood Experience score, of at least 1. 87% of the respondents had more than 1. And then again, because it was a managed care network, they saw their health records, right? And so they were noticing that the higher the ACE score of the individual, the higher their risk was for having health and social problems, to the point where they discovered that folks with a score of 4 or more, the likelihood of developing chronic pulmonary lung disease increased by 390% with a score of 4 or more. Hepatitis increased by 240%, depression 460%, your suicide risk increased by 1,220%, and the likelihood of you becoming an IV drug user increased by 5,000% when you had a score of 4 or more. And so what we see, and what the researchers discovered, is that there was a graded dose response. The more adversity you endured, the higher the likelihood you were to have adult morbidities and actually have a shortened lifespan. And further research has really dug into this, and they've discovered that there's actually a transgenerational or intergenerational phenomenon associated with it that is not just a behavioral type of a thing, but it actually gets right down into the epigenetics of these affected individuals that really then gets transmitted through, you know, procreation through their genes, and that the next generation is likely to have similar vulnerabilities. Now, this is really mind-blowing, right, when we think about this, and also the discovery about the pervasiveness of adversity in childhood. And as we all know, childhood is not the only time when we are exposed to adversity, when we're exposed to trauma. But when we do have that history, which the majority of us do, and certainly many of us have cultivated resilience and can move beyond that, there are still cellular and genetic remnants of that experience. Individuals with a trauma history actually become stress intolerant. They actually will manifest some significant psychopathology or psychological challenges, to include vulnerability for anxiety, depression. You already saw suicide there. In premature people, there's an increased risk in psychosis, major depression, schizophrenia, and bipolar disorder. So it's really important that when we're caring for these individuals, particularly, again, in the setting of a global pandemic, a global traumatic situation, that individuals with a trauma history are going to be more susceptible. And we need to be tuned into that for other, but also we need to be tuned into it for ourselves as well. Lots of folks now, in the wake of this, you know, kind of escalating discovery and awareness of how early life adversity undermines health and wellness, are trying to put together different conceptual models. This was a recent publication that I thought was really brilliant, and I love the graphics, that talks about this, you know, kind of staged HIT approach to individuals that are exposed to ELS as early life stress and CT as childhood trauma, that it leads to disruptions in critical phases of perinatal and juvenile brain development as a consequence of activation of the HPA axis, the hypothalamic pituitary adrenal axis, or your stress response. And so again, you have that genetic predisposition. If you're looking at the graph, there may be some fetal programming as well that can kind of confound the situation. So whatever the maternal situation is, if the mother is enduring some type of significant adversity, could be domestic partner abuse, maybe she also has a history of childhood maltreatment, all of that is going to affect and confer vulnerability to the developing individual. If that's then confounded with early life stress, for example, from my perspective, newborn intensive care, hospitalization, there's a whole bunch of other stuff that gets tossed onto this individual with regard to life-threatening situation, excessive and repetitive painful procedures, maternal separation, the #1 trauma experience endured by any mammal. And so all of these types of things, right, there's a cumulative effect of this stress to the individual that actually translates from an acute situation into a chronic situation, which actually is even worse, if you can even imagine that. Because in the setting of chronic stress, what we know now biologically is it activates what's called the neuroendocrine immune system. And so what happens is a chronic inflammation kind of is at the backdrop of this individual's physiology. So think about homeostasis, right? And you think about all the really cool, stable things that we need to have in place to be able to just kind of breathe, you know, me just sitting here breathing and talking to you, hopefully coherently. I might be having a little bit of stress doing the talk, but it's not overwhelming me. And that's what toxic stress does, or trauma does. It overwhelms the individual's ability to cope. So I'm doing okay, but I also know that I'm having a stress response. I can feel my pulse up a little bit. I can hear myself talking a little bit quicker than I normally do. But it's okay, because I know after this recording, I'm going to go back down to my baseline homeostasis. But when that stress is chronic and ongoing, what it does is it disrupts and degrades homeostatic integrity. And over time, it really can alter for the developing human, their developmental trajectory, but it also degrades intact tissue. So what I'm trying to say here is that when you have a stress response, right, we usually think of cortisol as the end product, but it's not just cortisol. It's a whole bunch of other inflammatory mediators, cytokines, interleukin, all the different numbers, toxic tumor necrosis factor, all these other things that are now at a low level, but they're at a level above where they shouldn't be, right? When we're not stressed, we're not stressed. But when we're chronically stressed, right, we have an increased risk for adiposity, cardiovascular challenges, and insulin resistance, and other types of things that sets the stage for adult morbidity and even older childhood morbidity. These allostatic processes, and allostatic is basically a fancy word for a stress response. Homeostasis is stability, allostasis is stress. It degrades our immune integrity then, because we've got all this activation going on of these inflammatory mediators. So it's multifactorial. And you can see here on the diagram, I definitely recommend you reading the paper. You'll just be blown away by it. Because at the end of the day, if these things go unchecked and unmitigated, you're going to see disparate health and developmental outcomes. You're going to see it not just physiologically, but psycho-emotionally and psychologically as well. And so when we come back to the trauma-informed paradigm, what this paradigm is really looking at is ensuring that the milieu, that the environment, that the care interactions are grounded with a focus on safety, facilitating choice, promoting collaboration and empowerment, and ensuring trustworthiness. And this may look differently in different clinical settings, but I think we can all agree, everybody's, like sold on safety, right? We're in healthcare. No one's going to say, yeah, I'm sorry, I'm against safety. We're all for that. And safety looks like a variety of different things. When I think about critically ill infants and pediatrics in general, probably adults, but I think about safety around prevention of pain and stress, protecting sleep, supporting optimal postural alignment and orientation, particularly for these individuals who can't move against gravity. I think about optimizing eating experiences. These set the foundation for the rest of their life, preserving and protecting their skin, promoting family participation, presence, proximity, both physical and emotional. All of these things are safety. And obviously the medical safety pieces too, right? So it's this big umbrella of safety. And then the choice piece, it's engaging with our patients. Now, a lot of patients right now, and yourself too, may not feel like you've got a lot of choice. We've got limited PPE. We've got all these other challenges, all these restrictions. I don't have a lot of choices. We have to balance that. We have to advocate for ourselves and for our patients, but also look at what choices are available to us and embrace those choices. Collaborating with the patient. Collaboration and choice, when I talk about neonates, it's cue-based interactions with the individual. Just because they're pre-verbal doesn't mean that they're not communicating with me as a clinician. So it's about taking all of that into play. And the empowerment piece, again, primarily in my world, I'm looking at empowering parents. How are you empowering your patients? You empower your patients. These are the constraints in which we're living in right now, but you can do this, you can do X, Y, and Z, and I want to see you do this. So we empower patients, parents, families to really maximize what is okay, what can we support in these crazy times. And that the trustworthiness piece just underpins everything. Because if we don't practice transparency, if we're not authentic, then we erode any kind of trustworthiness. We erode any type of therapeutic relationship that we can have with our patients and families. And to be honest, then, it's just, we're up the creek without a paddle, because trustworthiness really has to be a cornerstone of the relationship that we create with our patients and the relationships that our organizations create with us and the patients as well. It's an absolute human certainty that no one can know her own beauty or perceive a sense of his or her own worth until it's been reflected back in the mirror of another loving, caring human being. And that's you and me, right? You know, seeing each other, right? Seeing each other, seeing our patient, not just as the nurse, the doctor, the therapist, the patient, the gallbladder, however we do this, but seeing them authentically. It seems even more magnified in these unprecedented times, that's the least that we can do. I can't control for all these other limitations and resources, but you know what I can control is my presence with you, is my authentic healing presence with you, that I am here to alleviate your suffering, to help you feel comfortable, to make you not feel as lonely and isolated as you must feel during these trying times, maybe while you're taking your last breath. You know, so thinking about all of these things, this is what trauma-informed care is. This is what love looks like in healthcare. I'm a big Jean Watson fan, and I think she just magnifies what I said on the slide before. In her work on the unitary caring science, this was her newly published book, just came out in 2018. She says, we learn from one another how to be human by identifying ourselves with the other, finding their dilemmas in ourselves. What we all learn from it is self-knowledge. The self we learn about is every self. It is universal, the human self. We learn to recognize ourselves in others, and it keeps alive our common humanity and avoids reducing self or other to the moral status of object. This is a critical concept to not only just kind of get here in your head, but to get right here into your heart and into your soul. Because I think particularly, you know, in pre-COVID, what people are calling normal times, it wasn't normal. We were reducing our patients to their disease, to the constellation of symptoms that they presented to us. And we were just, you know, symptom managing and missing the fact that there was this living, breathing human behind all of those symptoms that needed to be seen, that needed to be cared for, even if we couldn't find a cure, to at least be seen. That's what we're privileged to do in this work as healthcare providers. And it has even more importance now. And I think, you know, if there is a bright side to this whole pandemic, I think it's the discovery that we are human. We do have a shared connection with each other. As Jean says, I learn more about myself when I am caring for you. And I want those lessons. I want to be reminded that we all are one, and that what helps you helps me, and vice versa. And that has meaning in clinical care. I love this really wise quote from the late Chadwick Boseman, that whatever you choose, remember the struggles along the way are only meant to shape you for your purpose. So think about all of the struggles that you're enduring just since March of this year. And now think how it has helped you grow. How it might feel like sometimes it's beaten you down and you're giving up, you can't do it anymore. In the next few slides, I'm going to help you move through that. But you have to remind yourself that these struggles really do shape who you are. They're a gift, if you can look at it that way. So all these struggles is a gift for the reality and the healthcare system that you're going to create for the future, for the healthcare clinician that you are still becoming. Just like I use the phrase becoming trauma-informed, there's not a destination because it's a continuous improvement. I am constantly growing and evolving and becoming the highest expression of who I came to be, who I can be, why I'm here. I think that that's the gift that we need to be embracing and not forget when all of this goes away, which won't be anytime soon. So take those lessons, internalize them, help them become part of who you are, because we're not here for the curing. We're really not, I mean, it's wonderful. It's wonderful. Absolutely. When folks are cured, when folks, recover from their illness and they go on and you can just feel so good that they're going to be healthy again. But there's bigger work that we do than just fixing the body, fixing the car, right? The car. It's my Boston accent. I apologize. I'm trying to work on it. We heal hurts, not just physical hurts, emotional hurts, psychological hurts, spiritual hurts. But the only way that we can heal them is by being present. And that's being trauma informed. Being present for the suffering of you and finding that suffering piece in me that can connect with you so that I can feel your feels. And in doing that, that sheds light on how I can best serve you then and mitigate and manage those hurts and heal those hurts. This is a brilliant quote that I wanted to share with you from the late Dr. Stephen Hoth. He was the one of the co-authors on the first paper that was introducing this idea of core measures for developmentally supportive care. We were talking about the infant, but this applies for all humans, right? He likened the care encounter to a Mobius strip. So a Mobius strip is one continuous loop. It turns on itself. So it's the inside is always the outside is always the inside, right? It's one continuous loop. And he said, neither the developing infant nor the environment exist in isolation, but rather intersect at this shared surface. In care interactions, there are not two separate surfaces bumping up against each other or two separate surfaces with an intervening space, but a single continuous loop structure, which is both organism and environment. When you're fully present with your patient and you're engaging in care with your patient, whether it's verbal or physical, you become a different organism, right? Like when you're talking with your adult patient, maybe you don't have to lay hands on, but you become this new dyad, this new entity, if you're fully present and you can feel the exchange, you can feel the energy, you can feel their feels, your intuition gets really turned on and you have this new connection. That's what trauma-informed care is. Trauma-informed care is love. And that's what we have to offer our patients, which is so highly relevant right now during these unprecedented times. But in order to really do that, right, we have to take care of ourselves first. You can't pour from an empty cup. We have to treat ourselves with gentleness, loving kindness, equanimity, and dignity before we can respect and care for others with gentleness, kindness, equanimity, and dignity. There's a really great quote from the Chicken Soup books, and it talks about how bearing witness to the suffering of others on a daily basis and thinking that it doesn't touch us, that it doesn't faze us, is like thinking that you can walk through water without getting wet. Bearing witness to the tragedies that befall humans, that bring them to the healthcare world, that bring them to you, your hands, your bedside, takes a toll on us. And it can be really overwhelming and daunting. And it can feel vulnerable bearing witness to tragedy. But when you lean into the suffering, even for a moment, you transform that darkness into love for the patient and for yourself. And I'm going to challenge you to think about those times when you actually did that and how you knew you had made a difference. You knew you had eased that person's suffering. You had helped them be seen. You helped them take a calm breath after so many struggling breaths. That's what trauma-informed care is. That's the invitation. That's what love looks like in these tumultuous times and beyond. This too shall pass. But I'm hoping that the message of love, the message of trauma-informed care won't pass along with it, won't fade away, that we'll remind ourselves and we'll remember how important it was and how important it always is in the care that we provide to these incredibly fragile, vulnerable individuals. I want to thank you so very much for your time, your attention, and I hope you found this interesting and relevant. As always, Take care and care well. Stay safe. And I hope to see you around.